right, so again, we are covering week 2, General Health and Survey. This is the second part of the video, pain. And pain now comes from the Greek word meaning penalty. Pain is whatever the person says it is, existing whenever he or she says it does. When doing a pain assessment, you're going to take note of the patient's pain history, looking at what their history is with pain, and again, this is subjective data. You're going to observe for behaviors related to pain, such as facial expressions, and also looking at physiologic changes, perhaps looking to see if there's an elevated blood pressure, elevated respiratory rate due to the sympathetic nervous system. Now, please note though, if this is chronic pain, then you will not see a change in those vital signs. But the patient will still be experiencing pain. A variety of behaviors can indicate that the patient is experiencing pain besides just verbally telling you that they are having pain. Many of these are nonverbal, such as moaning, crying, facial grimacing, guarding a body part, holding a body part, and reduced attention span, to name some of them. Table 8.3 in your textbook reviews age variations in the pain experience. And it is important to remember that age and developmental stage of a client will influence the person's expression of pain and their reaction to it. When assessing pain, our program uses the Old Cart and ICE acronym. It is on page 128 to 129 in your Health and Physical Assessment textbook. It has further information regarding what questions to use regarding open and closed-ended questions to help assist you in gathering the patient data related to pain. In this slide, what you're looking at with the smiley faces is the Wong pain tool, and it's often used for children so that they can identify how much pain they're having, and it's a nice visual representation. The top picture is a numeric rating scale, and this is often used with adults to assess patients' pain level. Of course, these are just simple tools, and after obtaining a pain number, further assessment will also need to be done using that Old Cart and ICE acronym. Referred pain is pain felt in an area removed from the tissue causing pain, and this picture shows you different areas of referred pain. For example, in the back, often called flank pain, you can see referred kidney pain. The nervous system must receive and interpret a stimulus to allow the person to recognize the pain process. The steps to this include transduction, transmission, perception, and modulation, and we'll be reviewing these over the next few slides. With transduction, it's the action potential that sends the impulse of pain across a pain nerve fiber. In transmission, the pain message is spread through the surrounding tissue, starting an inflammatory response and travels to the spinal cord and finally the brain, where it reaches the cerebral cortex to be interpreted and processed. With the perception stage, this is when the person becomes aware of the pain. The reaction to pain is the physiologic and behavioral response that occurs after an individual perceives the pain. If pain is not transmitted to the brain, the person will feel no pain. Also remember that when the brain interprets the pain, the person will also incorporate previous experiences, knowledge, and cultural associations related to that pain perception. Modulation is when neurons in the brain stem send signals back down to the dorsal horn of the spinal cord. There is a release of inhibitory neurotransmitters that work to reduce the pain effect and help produce an analgesic type effect. A theory related to pain is the gate control theory, and it identifies that pain can be gated or blocked along the central nervous system. It suggests that by blocking or gating the pain, that a diminished pain sensation is felt. Pain and other sensation of skin and muscle travel the same pathways through the large nerves in the spinal cord. If cutaneous stimuli other than pain are transmitted, the gate through which the pain impulse must travel is temporarily blocked by the stimuli. The brain then cannot acknowledge the pain while it is interpreting the other stimuli. A bombardment of sensory impulses, such as those from the pressure of a back rub, the heat of a warm compress, or the cold from ice applications, will close the gates to painful stimuli. The first response to pain affects your sympathetic nervous system, and your fight or flight response occurs. So with this, you see an elevated blood pressure, an elevated respiratory rate, an elevated pulse rate. When the body adapts to pain, there is a reversing of that physiologic response. This can occur several hours or days later, and then the pain behavior often becomes absent. You won't see the elevated blood pressure, the elevated respiratory rate, the elevated pulse rate. Developmental stages influence pain. Age and developmental stage will influence the reaction and expression and interpretation of pain. So it is important to be aware of that as you deal with patients. Children and infants do feel pain, and along with children and infants, the elderly are commonly undertreated for pain. Psychosocial development, family, cultural, religious beliefs affect pain treatment and expression of pain. An example your book uses is that Chinese Americans can be stoic and will not ask for pain treatment. The nurse needs to approach them. Also, a final factor that does influence pain is the environment. Examples of environmental factors: poorly fitting shoes, workers with carpal tunnel. And again, looking at a patient's previous pain experience. Was the pain treated, and did they tolerate it well? Or was the pain ongoing, very severe, and the patient had a very negative experience, affecting their interpretation now of their current pain response? On page 124 in your textbook, it compares acute and chronic pain. And again, with that chronic pain, you see that sympathetic nervous system response with the changes in the vital signs. Versus in chronic pain, vital signs go back to normal and parasympathetic responses kicked in. With chronic pain, patients often become depressed and withdrawn, and will not mention the pain unless asked. So it is always important to remember, regardless if you see a vital sign change or guarding or other pain behaviors with your patient, to always ask them their level of pain and to assess it. With oxygenation saturation, you're going to evaluate the effectiveness of a patient's oxygenation levels. The probe is placed on the finger or the earlobe of the patient, and then the pulse oximetry tool will give you a reading. 95 to 100% is normal. 70 or under is life-threatening. Again, always remember, pulse oximetry is a tool, and it is here to help you. However, it's always important to assess the patient and look at them in that comprehensive manner. When getting an oxygen saturation, be aware that nail polish does block the light and alter readings. Cold hands have poor capillary refill and will affect the reading. and can decrease the validity of that reading. If you have that concern, then use an earlobe monitor. Your skills book chapter 5 goes over how to obtain a pulse oxygenation, an oxygenation saturation. Blood glucose. This also is covered in your skills book. It's 1153. Times do vary with the actual blood glucose device, and there are many different devices. Blood pressure is also in chapter 5 of your skills book. Blood pressure is a force exerted on the arterial wall by pulsing blood under pressure from the heart. Blood flows throughout the circulatory system as a result of pressure changes. It moves from an area of high pressure to one of low pressure. Systemic or arterial blood pressure, the blood pressure in the system of arteries in the body, is a good indicator of cardiovascular health. The difference between systolic and diastolic pressure is the pulse pressure. For a blood pressure of 120/80, the pulse pressure is 40. The standard unit for measuring blood pressure is millimeters of mercury, and this measurement indicates the height to which the blood pressure raises a column of mercury. Record blood pressure with the systolic reading before the diastolic reading, for example, 120/80. Cardiac output is the stroke volume, which is the amount per beat times heart rate. And roughly, in most people, it's about 5.5 liters per minute. Blood volume is total volume in the vascular system, and it's about 5 liters in adults. Peripheral vascular resistance is affected by blood viscosity. The thicker the blood, the more increased resistance. And elasticity of vessels, the ability for those vessels to be compliant. Are they rigid, which causes more force to be exerted to get the blood moving? Factors that affect blood pressure. With increased age, there is a prevalence of hypertension. Males typically have a higher blood pressure. However, after menopause, females' blood pressures tend to rise. American males of African ancestry over 35 have a higher prevalence of hypertension. People who are obese have a higher blood pressure. Increase in physical activity will raise your blood pressure for a short duration. Stress elevates blood pressure. Diurnal variations, so blood pressure is usually lowest in the morning and then elevates throughout the day and with activity. And medications can obviously change blood pressure. Systolic blood pressure is the pressure during left ventricular contraction, and diastolic pressure is during the resting period of the heart. Again, it's measured as millimeters of mercury. And here I've included the Institute of Medicine's blood pressure classification, which also correlates to your skills book table, identifying that a normal blood pressure is less than 120 and over 80. It then goes over pre-hypertension and stage 1 hypertension and stage 2. To obtain a blood pressure, you will need a sphygmomanometer and a stethoscope. If the blood pressure cuff is too small, it will show an increase in pressure, and if it's too big, then it will falsely lower the blood pressure. The blood pressure cuff should fit the length and width of the patient. It's important to obtain a blood pressure in an arm without a mastectomy or dialysis shunt. This picture shows the Korsakoff sounds. Phase 1 is that tapping sound, and it goes through phase 5, which then is no sound, and it's the diastolic pressure. There's no pressure, so you hear no sound. Page 93 of your skills book goes over this procedure, and we will be performing it in the skills lab. And I did have this on here for the patient conditions that are not appropriate for electronic blood pressure measurement. If they have an irregular heart rate, a potential blood clots, narrowed vessels, they're experiencing seizures, then you need to obtain a manual blood pressure on this patient. All right, I look forward to spending time practicing with you guys in the skills lab. Thank you.